Pediatric UKM. Now, today we have got two presenters from the Department of Pediatric, Dr. Jasmine Lee, our registrar, and our specialist, Dr. Lee, who will lead the discussion of this case. We also are very fortunate today to have Dr. Amirah Farhanah from the Department of Pathology to discuss the chemical pathology of this patient. And we also have today Dr. Leong Huey from a clinical geneticist from Hospital Kuala Lumpur to share some light to the diagnosis and treatment of this patient at the end of the CPC. So I would like now to invite Dr. Jasmine Lee to present the case. She has been given this case about a week ago to work it out and to come up with a diagnosis. Dr. Jasmine?
Okay. All right. Thank you. Good morning to all. Chairperson, esteemed guests, colleagues, and audience on the floor. So moving on to the case. Hold on. All right. So we have a 11-month-old boy who presented to the private hospital.
Ya Allah, pada pagi ini kami mendedahkan yang berdoa kepada. Sesungguhnya Engkau yang Maha Berkuasa atas segala sesuatu. Ya Hayyu ya Qayyum, dengan rahmat-Mu kami mohon, perbaikilah urusan kami dan jangan Engkau serahkan urusan kepada kami walaupun sekelip mata. Ya Allah, sesungguhnya Engkau yang Maha Kaya lagi Maha.
Ya, Doktor, boleh teruskan?
Okay. So moving on to the case, we have an 11-month-old boy presented to a private hospital with a history of reduced oral intake for 3 days, low-grade fever for 2 days, diarrhea and non-projectile vomiting for a day. He developed an episode of blank stare at home before he was rushed to the private hospital, and he was noted to be hypoglycemic with a blood sugar of 2.1 millimoles per liter and referred to PTUKM 2 hours later. Upon arrival to the emergency department, he developed another similar episode and he did not regain consciousness since the first episode. His perinatal period was uneventful and he was the first child from a non-consanguineous marriage and had normal development. On examination, he was lethargic, his fontanelle was normotensive, but he did not open his eyes, he moaned, flexed his limb on painful stimulation, and his GCS was only E1, B2, M3. Vital signs showed that he has tachycardia with a heart rate of 165 beats per minute, BP of 99/54, and a heart rate, respiratory rate of 65 breaths per minute with deep subcostal recession. He didn't have a fever, and he was maintaining saturation of 100%. He had dry mucosa with a capillary refill time of 2 seconds with a normal pulse volume. An abdomen examination revealed hepatosplenomegaly with a liver of 5 cm and a spleen of 4 cm below costal margin. He was hypotonic with a power of 2/5 with lower limb reflexes, but other systemic examinations were unremarkable. So he's actually very unwell. And a dose of IV diazepam was given, and subsequently this boy was intubated and ventilated in PICU. Antibiotics were initiated. The initial labs that were taken during presentation shows FVC of leukocytosis with reactive thrombocytosis, a CRP, which is a normal CRP, 0.8 mg per liter. The renal profile is deranged with high urea and elevated creatinine for his age, which shows a sign of pre-renal acute kidney injury, probably due to the dehydration or volume depletion. The calcium is low, but other electrolytes were normal, and the liver function is deranged with elevated ALT and AST, more predominant over the AST component, which indicate there is some sort of hepatocyte injury, but the overall liver synthetic function is normal as the albumin is in the normal range. The arterial blood gas showed severe decompensated metabolic acidosis. Despite the child being tachypnic and hyperventilating, there was no respiratory compensation. There is respiratory compensation, but not enough. However, the lactate is normal. So we have an 11-month-old boy who presented with a red light syndrome after an acute illness with GI disturbance, and he has encephalopathy with hypoglycemia, hepatosplenomegaly with hepatocellular dysfunction, severe decompensated metabolic acidosis with acute kidney injury. So I've compartmentalized his main problem into 3 main groups. Seems that this boy previously who has been well, now is coming in with very severe metabolic acidosis with hypoglycemia, as well as a hepatosplenomegaly. He has an acute change in neurology with hypotonia, as well as liver dysfunction. So with these 3 main problems, and with a background of vomiting and diarrhea, I think I would need to consider these 4 differential first. Whether is this a case of severe volume depletion causing such acute and profound metabolic acidosis, or is this a case of severe sepsis causing a CNS or liver dysfunction? I will also need to consider acute drug poisoning due to this non-specific presentation with rapid progression and severe acid-base imbalance, or is this something more insidious like the acute metabolic crisis of an inherited metabolic disease? These 4 I will elaborate in the next 2 slides. But before I go on and talk about my differential, I would like to go back on the history first. Number 1, I want to know actually with this so bad acidosis, I want to know how severe is actually the GI loss that caused this presentation and the timeline of the disease. I would like to get the mother's, I will actually want to ask the mom whether has she noticed any abnormal smelling smell in the urine or sweat, any discolored urine or stools prior to this, and the exposure, and this is actually to look for any source of infection such as the food or milk handling that has precipitated this vomiting or diarrhea. Medication history, especially whether has he been given traditional medications or taken any prescribed over-the-counter drugs, the dosing amount and interval, whether it has been given appropriately or accordingly. I also want to know whether is there any previous similar presentation before this, or is this the first acute presentation of such severe illness? And even though the STEM mentioned that he has a normal perinatal history, I think a lot of times we missed out a more detailed antenatal history in terms of whether is there any history of recurrent miscarriage, previous neonatal deaths, or stillbirth, or any death that preceded a viral illness. I would want to know about his growth, whether is he small or thriving, or any faltering growth throughout his growing years, or as well as the feeding history or feeding difficulties that he had encountered before. And although it was mentioned that he had a normal development, but he seems to be having hypotonia. So a more thorough history into the gross motor development, such as whether he was floppy at birth, any delay in turning or sitting, or any marked head lag that was noted before, it will be helpful. And for family history, I think if we are thinking of metabolic cause such as the X-linked or mitochondrial diseases, we will see that I would want to know whether is there any affected males from the maternal side, and a 3-generation family tree will be helpful to uncover certain inheritance pattern if there is a familial cause. And for physical signs, looking at the picture, if it was a metabolic cause, I would actually want to look for any signs of storage disease or soft dysmorphism that could give us some signs such as cause facies or any doll face, signs of growth failure. So getting his anthropometric measurements, his head size, whether he has macrocephaly or microcephaly, look at his serial growth chart, his muscle bar to look for any muscle wasting, his eye assessment since he's encephalopathic, his pupil size, whether is it equal or reactive, any abnormal eye movement, more thorough investigation like cataracts, corneal clouding, which may uncover certain metabolic diseases, and a neuromuscular assessment looking for focal neurological sign that may localize some brain pathology. So he first came with vomiting and diarrhea with severe acid-base imbalance with hypoglycemia. At first, I think I would consider this a feature due to a case of severe dehydration, but it makes it a bit unlikely because although he's clinically dry and tachycardic, he does have a normal fontanelle, anterior fontanelle is normal tensive with good pulse volume. There is actually no signs of shock if looking at the heart rate is actually appropriate to his age, and the tachycardia can be due to probably dehydration or some volume depletion. And in the case of very severe dehydration with such severe acidosis, the lactate would probably be raised, but he has a normal lactate. And normally, usually in this kind of case, they may not have a hepatosplenomegaly, and we would expect an electrolyte imbalance, but in this case, he doesn't have it. The next thing I would want to consider is whether is this severe sepsis. Yes, he does fulfill the criteria for severe sepsis. He does have a source of some infection with tachycardia, tachypnea, with abnormal leukocytes. He has some augmentation with liver dysfunction. However, in this case, if you're thinking about a CNS infection, hypotonia would be contradictory in the case of meningitis or meningoencephalitis. I would expect the CRP to be higher in the case of severe infection, which is normal in this case. And in the case of severe sepsis, normally, and with such profound metabolic acidosis, usually the lactate also will be high due to tissue hypoperfusion, in which he does not have, and he does have a normal BP. The next thing I want to rule out is a case of drug poisoning, and this is probably due to the acute onset of non-specific vomiting and diarrhea, severe acid-base imbalance, and liver dysfunction. But again, what contradicts it is there is no history of drug ingestion, probably need more thorough clarification with the guardian later. And let's say aspirin poisoning usually have a mixed pattern of acid-base imbalance. They usually come with respiratory alkalosis, which progress to a high anion gap metabolic acidosis with high lactate. While paracetamol poisoning comes in a spectrum of mild hepatitis to a fulminant acute liver failure, in which again, this will be helpful if we have a serum salicylate or paracetamol levels. And looking at the features of this unexplained metabolic coma with profound acidosis, hypoglycemia after a period of unwell, and involvement of the liver with hepatosplenomegaly, I strongly think that this is probably a case of acute presentation of a metabolic disease in crisis, which I will further divide the differential into 3 main groups. Number 1 is the disorder that gives rise to intoxication, or is it a disorder involving energy metabolism, or a disorder involving complex molecules? So again, before I talk about these 3 big groups differential, I would like to make sure there are a few bedside investigations to further narrow down the diagnosis. So number 1, whether with this metabolic acidosis, I want to know whether is there presence of ketosis, what is the anion gap, and the ammonia levels. And the first line, and this will be the first line investigations before going on to the differentials, and other supporting investigations like a coagulation profile, cultures to rule out any infections, because he's coming in with such neurological, acute neurological change. We need to consider a lumbar puncture to rule out CNS infection, and an ultrasound cranium prior to the LP to ensure there's no signs of increased intracranial pressure. Ultrasound abdomen is not really helpful, but it's actually to help us look for the echogenicity of the liver and spleen, whether is there any signs of hepatic stenosis or splenic infarct, and drug levels for salicylate and paracetamol levels. So for my differentials, to start off, so this boy came in with, he had a history of a normal perinatal and postnatal period with rapid progression into lethargy and coma and a profound metabolic acidosis. So this one usually, some disorder that involve this kind of small molecular disorder in a metabolic pathway may present with this, such as organic acidemias, aminoacidopathies, and urea cycle disorder. But what is against it is usually these children presents much earlier within the neonatal period, from few days to weeks of life. Urea cycle defects usually will have hyperammonia with alkalosis, but some of them do have severe metabolic acidosis. Maple syrup urine disease, sometimes in history, they have some characteristic smell in the urine, and the urea cycle disorder usually have certain patterns of neurological signs. So in terms of specific investigation, so again, need to look, usually they will have a ketosis with severe metabolic acidosis. A plasma amino acid would be helpful to confirm a maple syrup urine disease. Levels for urine organic acid or uric acid, which can be helpful in the case of organic acidemias or urea cycle defects. ammonia levels, ammonia usually will be very, very raised in the urea cycle with a very low urea. And from history-wise, usually maple syrup, urine disease, and some sort of organic acidemas have distinct urine smells. The next differential I will consider is whether is this mitochondrial fatty acid oxidation. So to support it is he come in with acute hypoglycemia with encephalopathy accompanied with hepatomegaly and liver dysfunction. This hypoglycemia, again, I need to find out whether it is ketosis or not. Usually for this kind of problem, it will be a hypoketotic hypoglycemia. And they come in very, they will also again present with initial free interval period triggered by illness and then comes in with a rapid progression. But the argument against this is usually they come in much earlier in the early childhood, early infancy, and splenomegaly is not a feature. So further investigation to actually look out for is probably any history of neonatal hypoglycemia previously. ECG and echo is actually to look for the complication. So normally they may have cardiomyopathy. Urine serum ketone to help us to narrow this differential, and dried blood spot or plasma acyl carnitines. This case, they might be they will be raised in these problems. Urine organic acid, which will be elevated during fasting, which will also help with this differential. And also other specialized tests like free fatty acids and ketone body and plasma free and total carnitine concentration. But this one are very more second tier investigation. Definitive will probably be enzyme assays or mutation analysis. The third differential that I would want to think of is whether is this a ketone body metabolism. So whether is this, so points towards it is, again, they are quite similar to fatty acid oxidation defects where they come in acutely with hypoglycemia, the hypoketotic type, and encephalopathy with liver dysfunction and hepatomegaly. But the argument against it is usually they present earlier and splenomegaly is not a feature. Again, the investigation is also similar to the fatty acid oxidation, but these are quite rare and normally usually will need a definite tissue biopsy or enzyme assay with some sort of molecular analysis to confirm the diagnosis. While lastly, I would like to consider whether is this a disorder involving complex molecules such as storage disorder. Looking at him, he come in very acute. Storage disorder usually are quite chronic, progressive, and they are associated with developmental delay and distinct facial features. But the supporting feature is this boy has hepatosplenomegaly with hypotonia, fasting hypoglycemia. What he does not have is probably lactic acidosis, which normally in glycogen storage they will usually have. So to consider this, I think in terms of lysosomal storage disorder, I would like to do a full blood picture looking for vacuolated lymphocytes. Serum triglyceride and uric acids are some markers that can be raised in glycogen storage. Echo to look for any cardiomyopathy such as in Pompe infantile onset disease, and urine for glycoaminoglycan and oligosaccharide. These are also secondary screening tests to rule out some sort of certain lysosomal storage problem. But definitive investigation would be probably enzyme activity assay or next generation sequencing. So to continue on, his blood gas after 2 days of intensive treatment noted to be metabolic alkalotic with hyperglycemia. But on the day that was scheduled for lumbar puncture, a feeding was withheld prior to the procedure, and the child was put on half saline dextrose, 10%. However, after that, his arterial blood gas was noted to be becoming metabolic acidosis. However, his glucose seems to be normal. So looking at all the differentials that I put right now, before that, I also want to know whether is there any presence of ketosis. And then if there is presence of ketosis with a background of normal glycemia and a normal lactate, I will narrow down my differential to probably a maple syrup urine disease, but a late onset forms or keto body metabolism or some sort of organic acidurias. Yeah, so that would be from me.
Thank you, Dr. Lee. Now, if you have got a very comprehensive list of differential diagnosis, if you would like to rank it for us, what would be, number 1, number 2, number 3, number 4?
Okay, so let me share back my screen. I think in terms of this acute presentation, with this, the main thing is actually the severe metabolic acidosis, and hypoglycemia can be because of the liver dysfunction, but he's very young, very acute onset with encephalopathy, ray-like picture. I want to put the disorder that gives rise to intoxication, this as the first diagnosis, followed by mitochondrial fatty acid oxidation. The last I would consider is probably storage disorder, because normally they don't present so early. Only very certain, like glycogen storage type 1 will have, but again, they will usually have marked lactic acidosis, high lactate, which this child doesn't have.
So you think that this child spells more metabolic compared to the rest of your diagnosis, your differential of sepsis and dehydration?
Yes.
Any other reason for that?
Well, if you're talking about dehydration, if we look back at the history, he did, well, even though he came in with history of 3 days of unwell, but his vomiting and diarrhea is probably 1 day. So I would actually want to know how much was he actually having profuse loss, and in terms of his clinical features, it doesn't look like a dehydration picture. He was only dry and tachycardic, but his other, like fontanelles, was normal. His BP was normal, lactate was normal as well. Same with sepsis. So sepsis, we would expect a higher CRP, some sort of high tissue hyperperfusion, which he does not have.
His subsequent progress in the ward, does it give you any other clue that it's a metabolic disorder?
It seems that he improved quite rapidly after, I'm not sure what kind of intensive treatment, but probably he have received some sort of fluid resuscitation or maybe some correction in terms of the metabolic acidosis. So there was improvement in the acidosis, and also there's no more hypoglycemia. However, when he was fasted, you can see that there's a change in terms of his acid base, but his glucose remains normal. So
with this fasting and the sort of decompensation, can you narrow down to your differential diagnosis?
So with a background of metabolic acidosis, whether or not is there any, so I want to know first, is there any ketosis? And if there is a ketosis with a normal glucose at this point of time, so the differential will probably also be some sort of organic aciduria, and then some ketone body metabolisms.
Okay,
like
Dr.
this.
Lee, can you give some answers to what Dr. Jasmine has in her questions? Do you want to provide her with some answers so that she can work it further?
I will share my screen. Thank you, Prof. Wong. Jasmine, thank you very much for the very comprehensive description. Okay, so I will review some.
Slideshow, Patron.
Or maybe let me answer to Jasmine some of the questions first on the history. Then I will give her the investigation. I'll stop share. Jasmine, can you just show me your slides and I'll go through one by one of whatever all the questions that you asked for.
So actually the main thing I want to know is presence of ketosis, and ion gap and ammonia levels.
I'll start with your history first. You want your clarification of your history?
Yeah. Yes.
Okay. The things that I've jotted down is that your the GI loss, you wanted to clarify the history of the GI loss is as what is stated. It's just 3 days of fever and then just a day of vomiting upon presentation. He was apparently completely well. His urine and sweat was not noticed to have any abnormal odor, and then the urine and stool looks as normal as it could be for a baby of 11 months. And as for the food and milk handling, we find there was no issue to it. Medication history-wise, on the second day of illness, he actually presented to one of the private pediatrician and was just given some ORS, and at that time during the examination he appeared to be apparently quite well. So they actually treated him as
Dr. Lee, in the interest of time, can you summarize whether there's any abnormality in
no abnormality, no previous history, no previous presentation of seizures. The antenatal history of whatever we got was as what is stated. Growth, gross motor development, everything else looks normal. Family history, as far as we looked at it, we didn't notice any.
Okay.
Yeah. So then that's it, right? The history. Examination, we also didn't find anything abnormal. Eyes examination, normal. And then neurological examination, there was no focal deficits. It's just hypotonia and bit of reduced power.
What's the head size?
The head size was it's actually at the 25th centile. The height and weight was at the 50th centile, and he was actually growing well. It's between 25th to 50th centile for the head size.
Okay. Maybe you can provide with the answers, the metabolic. Yeah.
Okay, right. I will share my screen for the investigations that you wanted. Okay, so these are what the investigations you've requested. The site lab that we got, this will probably help you with your anion gap. We found a serum ammonia of what is actually written there, and that's the serum ketone and urine ketone.
Okay. So from this investigation, we can say that he has a high end ion gap metabolic acidosis with an ion gap of around 30, and he has hyperammonemia, and hypoketotic. Yes, there's no ketosis, hyperammonemia, as well as site lab, high end ion gap metabolic acidosis.
Just let me clarify with a bit.
So wait, what does it mean? You wanted the ketone, you wanted the anion gap, and you wanted the ammonia in your presentation. So has it helped you narrow down your differential diagnosis?
Sounds from this, I think I will need to consider this is a case of urea cycle defect, because normally urea cycle defect, they do have very, very high ammonia levels and hypoketotic.
Mm.
Your renal profile, do you want to have a look at it? And
sorry, can I say something? Just to say that urea cycle disorder do not have a hypoketotic.
Oh, okay.
Yeah.
So any other differential?
Yes.
And your urea is a little bit on the higher side, right?
Yes, the urea. Oh, yes. So urea cycle defect usually will have a low urea. So if hypoketotic, hypoglycemia with a background of high anion gap metabolism and hyperammonemia, sorry, I just go back to my slides again.
Sure. Yeah, let me unshare.
Probably I think either a ketotic lytic defect or fatty acid oxidation defects.
Yeah.
Okay. Dr. Lee also mentioned that in her slide that there's a possibility of a hyperlipidemia. What does that mean?
Hyperlipidemia, so there's a defect in the lipid metabolism. So I think the only thing that I can think of for hyperlipidemia is probably fit some sort of storage disease like glycogen storage disease. But looking at normally glycogen storage disease, I'm not sure that they come in with very severe metabolic acidosis.
No, you mentioned maybe a ketolytic defect, and what else just now you said just now?
Fatty acid oxidation.
Yeah, so FAOD. Now, if there is hyperlipidemia, possibility of a hyperlipidemia, which pathway is dysregulated that caused high lipid?
So high lipid meaning they cannot have like high lipolysis, so causing increase in the triglyceride. So I think probably fatty acid oxidation defect, they cannot I'm not sure this one.
Okay, Dr. Lee, can you proceed further?
Can I just answer that
Okay.
question on her behalf? All right, there's one GST that is hypoketotic, but just one GST type 1. So it's good to consider that in the presence of hypertriglyceridemia, hypoglycemia, and also hepatomegaly. But the rest of the GSTs have ketones.
Dr. Lee,
Thank
can
you.
you proceed further? Dr. Lee, do you have any more slides to show?
Yeah, okay, so
Yeah.
or maybe we let Dr. Amirah tell us what happened to the ammonia until we got the, then after that we really confirmed that the lipid profile is actually very deranged in this child. And then we had to actually ask for the pathologist for help in further processing the ammonia.
All right, Dr. Amirah from Pathology Department.
Assalamualaikum and a very good morning to Chairperson Professor Dr. Wong Huey, respectable speakers Dr. Jasmine Lee and Dr. Lee Pei Chuen from the Pediatric Department, as well as Dr. Leong from the Genetic Department HKL. So basically my presentation today, I will focus more on the biochemical investigation and the analytical interference in this case. Oh, sorry. So my objective of presentation is to discuss the basic biochemical investigation results and to discuss more on the method of ammonia, as well as to explore the interference and a little bit to discuss on the inbound error of metabolism screening result. So I think Dr. Jasmine has presented very well just now that demonstrated that the patient has high anion gap metabolic acidosis, as well as some acute kidney injury and transaminitis and hypocalcemia. And the bedside ketone shows that the patient is hypoketosis. And from the ammonia level, we actually received 3 samples of ammonia on the same day. The first sample received was at around 9 in the morning, where the measurement gave a result of 97 micromole per liter, which is at the borderline high level. And then the second ammonia result received was at around 12 p.m., which is 173 micromole per liter. And this result is produced after autodilution by the analyzer. And the third ammonia that we received at 3 p.m. Showed a flag of no absorbance, as there was no absorbance being able to be read by the analyzer within the absorbance spectrum of ammonia. So actually the first sample that triggered us upon the possibility of a difference is actually on the third ammonia sample at the 3 p.m. And when we look back actually at the analyzer insert, our analyzer actually is able to measure the ammonia from 4.7 to 997.9 micromole per liter. So when we look back at the second ammonia sample, the level of 173 micromole per liter was still actually within the analytical measuring range, hence trigger the possibility of interference in the sample, because the analyzer prompted an auto dilution rerun. So why did the analyzer perform an auto dilution on the second ammonia analysis? So when we look back and we try to retrieve the sample from the storage, as you can see in the picture demonstrated in this slide, the second and the third ammonia sample was grossly lipemic. As you can see, is quite a bit and does not look like a normal serum. And it was found that the analyzer was unable to calculate initial result on the second sample since no absorbance was read. So they prompted a rerun with dilution on the second sample, but the result was released automatically. Hence, we did not catch the possibility of interference on earlier. So on the third sample, the visual inspection here shows grossly turbid sample. However, the lipemic index, automated lipemic index performed on the analyzer showed only 1+ index. And we asked the clinician to send a sample for serum lipid, and it shows that the triglyceride of the sample was very high at 11.34 millimole per liter. And we have tried to centrifuge the sample using high-speed centrifugation at around 13,000 RPM to extract the lipid layer, but the analyzer was still unable to produce an ammonia results. Hence, the result was not reportable. And this is the serial ammonia measurement, as I mentioned earlier. The first was 97, subsequently followed by slightly increased ammonia at 173. And the ammonia at the 3 p.m. was not released because of the interference caused by the lipemia. And as the patient subsequently undergoes treatment, we can see that the ammonia level comes down to 28, and the triglyceride as well has reduced to 3. And this is the trend of the lipid profile, where you can see the reduction of the triglyceride after management, as well as the slight reduction of the total cholesterol. The LDL here is cannot be calculated because the LDL is a derived values where it is calculated using Friedwald equation, and it cannot be calculated if the triglyceride is more than 4.5 millimole per liter. So a little bit on the technical part on ammonia analysis. We use the Abbott Architect chemistry platform using a calorimetric detection. So the method that we use for ammonia is glutamate dehydrogenase, where in the presence of glutamate dehydrogenase, ammonia combines with alpha ketoglutarate and NADH, and it will cause a conversion of NADH to NAD+, and the decrease in absorbance is detected at 340 nanometer, which is proportional to the concentration of ammonia in the sample. So usually sample requirement for ammonia, you will require a plasma sample, EDTA or lithium heparin, and usually we suggest the sample to be placed on ice immediately upon collection, and it is best to send the sample immediately to the lab within 15 minutes because rapid separation of plasma from RBC is critical. And the interference of lipemia, when we talk about interference, interference is a deviation from the true value of analyte caused by presence of either endogenous or exogenous substance. And the frequency of lipemic samples received varies between lab around 0.5 to 2.5%. And as we can see, if you can see the diagram on the left, the lipemia causes light scattering across the visual spectrum from 300 to 700 nanometer, which increases as the wavelength decrease. And our analyte of interest today is ammonia. It is measured at 340 nanometer, indicated by the dotted line, shows a very high disturbance by the lipemia. And all assays that utilize changes in ADP concentration, which is measured around 340 nanometer, are susceptible. And other than the interference in the absorbance, other mechanisms of lipemic interference include volume displacement, for example, pseudohyponatremia, but this is usually seen at a higher concentration of triglyceride, usually more than 17 millimole per liter. And it can also cause differential proportioning of analyte between polar and non-polar phase, especially in lipid-soluble analytes, for example, our steroid hormones and also some drugs, and as well as interaction of lipoprotein particles with assay reagent. And from the ammonia reagent kit provided by the manufacturer, usually when the manufacturer develop a test, they need to validate the test and perform an interference study where they spike a sample with known concentration of analyte with possible interfering substance. For example, in our interest of lipemia, despite the sample with intralipid, and they have found that significant interference of ammonia measurement is noted when the sample is spiked with 100 milligram per deciliter intralipid, which is equivalent to 1.13 millimole per liter of triglyceride. And as I mentioned earlier, a rapid separation of RBC is usually recommended because the intracellular or the erythrocyte contain a lot of ammonia compared to the plasma. So any degree of hemolysis can cause large bias in the level of ammonia. So these are the possible causes of lipemic sample. It's either can be caused by primary hypertriglyceridemia, for example, in lipoprotein lipase deficiency or apolipoprotein C2 or A5 deficiency, as well as other commonly seen secondary causes of hypertriglyceridemia, for example, in patients with uncontrolled diabetes and chronic kidney disease, as well as nephrotic syndrome. And other than that, for patients with high protein in the blood or patient with paraproteinemia can also cause lipemic sample due to the protein content of the serum. The pre-analytical cause of lipemia include a postprandial sample, where patient sample was taken just after they took a large meal, and the sample can be turbid because of large content of chylomicrons in patient sample, and those patients with parenteral nutrition can also have lipemic samples. So how do we actually detect lipemia in the lab? We can perform visual inspection, or we can use lipemic index from the automated serum indices, as well as perform triglyceride measurement. So from the visual inspection, usually is a manual process, and it doesn't require analytical tool. It can detect visually if the triglyceride is more than 3.4 millimole per liter. However, it has low sensitivity and high inter-individual variability because of the manual processing. And the lipemic index can be measured by the automated serum indices. So it's an automated process with negligible cost, and it has been demonstrated to improve the laboratory turnaround time, and it provides an objective measurement with increased reproducibility. However, this measurement is usually semi-quantitative, where we report it as 1+, 2+, 3+, or 4+, and there is lack of harmonization between manufacturers, where some report semi-quantitative and some manufacturers do report quantitative measurement. And the lipemic index also is subject to interference, as it also utilizes the spectrophotometric detection. The third method of detection is by using triglyceride measurement, where it provides an accurate measurement of triglyceride in the serum, and our lipoprotein that cause turbidity are usually the triglyceride-rich VLDL and chylomicron. However, this our proportion of triglyceride differs among lipoprotein, and the degree of turbidity has been shown to have a poor correlation with the triglyceride concentration. So usually in the mitigation of lipemic sample in the lab, what we do is if the patient is lipemic due to exogenous cause, for example, the patient just received TPN, we can reject the sample and advise the clinician to repeat the sample later. And if it is caused by endogenous lipemia, we can attempt to remove the lipids by performing dilution or using lipid clearing agent, ultracentrifugation or high-speed centrifugation. For lipid clearing agent, it is not available in our center, and you need to perform a verification in your own lab because it has been reported to cause low recovery of many analytes. Ultracentrifugation is currently the gold standard or the recommended standard to remove the lipids, but it is not routinely available in the service laboratory. And by performing ultracentrifugation, you can reduce the triglyceride up to 7-fold. And what we did was we did a high-speed centrifugation. It can reduce up to 4-fold decrease in triglyceride, but we did not manage to decrease the triglyceride up to the level that does not cause the interference to the measurement. Another method is you can perform dilution, but by performing dilution, it involves a manual process, and it adds an uncertainty to the measurement. So it is up to the jurisdiction of the pathologist as well as the clinician who saw the case whether to process the sample or not. Next, I will talk about the result of the inborn error of metabolism screening on this patient. So these samples was sent to the IAM
Dr.
lab.
Amirah, maybe we
Yes.
should just skip this first.
Okay, sure.
Yeah, we will come back to you later.
Yeah, sure.
Yeah. Dr. Jasmine, you have a bit of time to think about the diagnosis, given that, thank you, Dr. Amirah, as well, for your very good explanation about the interference. What would you be in your diagnosis now, knowing that you summarize it as low ketone, normal ammonia, high anion gap, and also hypoglycemia, and a lot of lipid in the serum. Which pathway could be wrong in this patient? Can you unmute?
Okay. It's probably looking more towards some accumulation problem in terms like a storage disorder. I know one of the disorder, like glycogen storage type 1, like what Dr. Leong mentioned, does have hypertriglyceridemia. They have fasting hypoglycemia as well as non-ketotic hypoglycemia. But again, the high anion gap metabolic acidosis, okay, so they come in usually with also lactic acidosis, which can also precipitate high anion gap metabolic acidosis. But in this case, this child doesn't have a high lactate, but he does have a high anion gap metabolic acidosis. That's one of the contradicting features. But looking at the other features like fasting hypoglycemia,
you had in your graph just now, you had other differential. What else could you consider apart from the storage disease with low ketone?
Low ketone.
Ah.
So, and another thing would, I think
when you're fasting, what kind of energy source you will use if you're fasting?
Fasting you can it's probably anaerobic metabolism. So the pyruvate pathway would probably be involved. But this one I'm not too sure about.
At the end of our puasa, what will happen to your ketone body?
The ketone body will be,
if you are normal,
it will be utilized.
Yes, so you want to use it, you utilize that. But in this patient, is it being used?
Probably not, because the ketone is hypoketotic. So it means that in the form of hypoglycemia, usually will have ketosis, but he doesn't have that response. So that's why he's hypoketotic. So probably he couldn't use his ketone as ketone body. So probably it's part of a ketone body metabolism type of defect.
So can you explain now why is the lipid very high?
Why is the lipid very high? Probably it's because there's no lipolysis.
There will be a lot of lipolysis. You convert your fat to lipid, your body fat.
Not sure.
Okay, never mind. So with this kind of preliminary first tier investigation result, how would you approach this patient? How would you confirm your diagnosis? What investigation do you do?
So I think in terms of, let's say if it's a ketone body metabolism, I will consider to send the plasma dried blood spot for acyl carnitines, as well as free fatty acid and ketone bodies to see whether is there, is it raised or not. Probably, I think if you're thinking of storage disease, then, some sort of biopsy, tissue biopsy would be also helpful to look for any sort of, signs of storage in that.
What biopsy? What tissue biopsy?
Probably like liver biopsy to look for,
Okay. Dr. Lee, you have flashed the approach to hypoglycemia part. And so if you look at it in your patient, Dr. Lee, Dr. Jasmine, where would your patient be?
So it'll be at the fasting hypoglycemia with low normal ketone with metabolic acidosis. And yes, I know, yes. So fatty acid is, so I need to know the free fatty acid level to see if it's low, then glycogen storage would be possible. If it's high, then the fatty acid oxidation or ketogenesis defects would be another.
Okay. All right, thank you. I think we are very short of time. Can I invite Dr. Leong to give us some of the results and the diagnosis of this patient? We have unmute, can you?
Yes, okay. So just to clarify, I will be reviewing the diagnosis, revealing, and also discussing the diagnosis in my sharing. Okay, so Dr. Jasmine, here is the diagnosis. Okay. So I will give a summary regarding this condition. Mitochondrial 3-hydroxy 3-methyl-glutarate-CoA synthase deficiency. And this in short is HMG-CoA synthase deficiency. We will try to understand whether the case that we just heard actually matches this and what are some of the other considerations and also typical features and treatment. So this is actually a disorder of ketone synthesis. So unfortunately, the chart which Dr. Jasmine used is is the standard textbook for metabolic physicians. However, besides ketolytic defects, which is listed there, actually the ketone synthesis should also be listed in the same category of hypoketotic hypoglycemia. So basically, our body produces ketone bodies, and the main ketone bodies produced are acetoacetate and 3-hydroxybutyrate. And these are used especially for energy during fasting. So for high energy need cells such as cardiac and skeletal, they are definitely needed in fasting. And brain in particular, we cannot use the free fatty acids. So free fatty acids are freed from our lipid store, but it needs to then be converted to ketone body to be used in particularly by the brain. This is a very brief understanding of glucose homeostasis during fasting, and this actually would represent adults, I would say. So initially, when we have a meal, our glucose will come directly from absorption from this meal for the first 2 hours. Subsequently, if there are complex carbohydrate, it may last us until 3 to 4 hours. If we do not eat after that, glycogenolysis needs to kick in, and this is actually us retrieving glucose from our glycogen. Liver is the main organ that would supply glucose to the plasma to be used by all cell types. Although skeletal muscles have their own glycogen store, which they will use in exercise. So this kicks in from 3 to 4 hours. Subsequently, if we continue not to eat, the glycogen stores will drop and the gluconeogenesis kicks in. Now, this is where we use glucose from non-carbohydrate source. So some of the sources which can be used is protein. So glucogenic amino acids are used in gluconeogenesis. The other one is lactate in anaerobic cell respiration. The third one is actually glycerol. And this glycerol actually comes from lipid metabolism. So when there is hypoglycemia and there's no more glycogen or less glycogen to be used, actually the lipid metabolism also goes into overdrive, and triglyceride will be used or will be released a lot. And that's where we see, we're not sure exactly the mechanism, but that's where we see actually triglyceride is raised in a lot of conditions regarding whether it's a glycogen storage, where there's glycogenolysis defects, or where there are other conditions that causes hypoglycemia. Now, fatty acid oxidation comes into the picture when we fast, usually beyond 12 hours. So we need to then access our fat store for glucose metabolism. So fatty acid oxidation disorder is where actually we use to also produce ketone body. So ketogenesis defects are actually in this category where we say that with prolonged fast, we may go into problems. However, in infants, this graph actually moves all to the left. There is less glycogen store, there is less gluconeogenesis ability. They actually use the fatty acid much earlier, some as early as 4 hours. As they grow, then it becomes 6 hours, 8 hours, which means that those with fatty acid oxidation disorder present with a shorter fast when they are younger, right? Now, this is the pathway for, it's the same textbook which Dr. Jasmine used, and I want to acknowledge Dr. Andrew Morris, who actually wrote this chapter. So disorder of ketogenesis and ketolysis. So in the middle of the chart is the main ketone body, acetoacetate and 3-hydroxybutyrate. And these are actually obtained from the main pathway for ketogenesis is actually free fatty acid. There are actually two main enzymes for ketogenesis. One is HMG-CoA synthase, which is what this patient has, and the other one, yes, is HMG-CoA lyase. So that's why these two actually is in the same category. T2, which is beta-ketothiolase, actually is not the rate limiting step, and therefore, when there's a deficiency of T2, right, actually they do not present with a ketogenesis symptom. They actually present with a ketolytic. So this enzyme is required to produce acetyl-CoA from ketone bodies. Is a ketolytic defect. So T2 and Scott actually presents like a ketolytic defect where actually the ketones are very high because we are not able to use the ketone bodies that is produced. And Dr. Jasmine mentioned very briefly, so we just mentioned. So there are receptors called MCT1, the main receptor MCT1, another additional receptor MCT7 that is used to move ketone bodies within compartments. So ketone bodies produced in mitochondria need to move out of mitochondria into the cytoplasma, requires MCT1 and 7, then moves out of the liver cell into circulation, and from circulation going back into blood-brain barrier. So that is why even the receptor or transporter defect also may cause hypoglycemia. All right. Okay, so the two enzymes for ketogenesis. All right, so HMG-CoA synthase is encoded by this gene, HMGCS2, and this is inherited autosomal recessive. So regardless whether the offspring is girl or boy, each offspring has a 25% recurrence risk if the parents are confirmed carriers. So this is the first child. If there is any further child, every child has a risk of 25% and requires screening and treatment. Okay. So these clinical features, basically the age of presentation varies throughout life. Although typically we understand that a lot of inborn errors is supposed to maybe present themselves in early life, those typically that we know in the first few days of life. However, many of the same disease, because if I have a residual enzyme that can take me through my early life without any problems, then it's really I'm able to go through the early life without any symptom. So what we just need to bear in mind is that actually inborn errors of metabolism present throughout life. So it has to be a differential whether they present at day 3, 1 month old, or even this patient at 11 months old. Right? Usually it's precipitated by intercurrent illness is because they can actually still have access to sugar only when they don't have enough gluconeogenesis and glycogenolysis ability, then they're in problems. So it's a severe, usually catabolic state where more energy is needed by the cells or in fasting state. The symptoms are related to a decompensation, very much related to actually a shortage of sugar in our brain cell. So sometimes present similar symptoms of encephalopathy. And then the severe lactic acidosis is because everything else goes into overdrive. And of course, when all the cells are then hypoperfused, it will just worsen the cycle. So there's lethargy, reduced consciousness, and encephalopathy, very non-specific symptoms. Just as Dr. Jasmine said, actually the differential diagnosis is long. Then there is acidotic breathing with metabolic acidosis, and sometimes there is lactic acidosis, sometimes there is not. Hypoglycemia is typically described non-ketotic, but because there are cases where there are ketones being detected, so now we say that they are hypoketotic. So they would have the transient hepatomegaly with raised liver transaminases with or without hyperammonemia. Now, FAOD is a secondary inhibitor to the urea cycle. Biochemical features is actually not much for this condition, HMG-CoA synthase. Therefore, actually, it's very difficult to diagnose it. There is this when we send the urine organic acid, we will see this dicarboxylic aciduria, but this is non-specific. In any conditions where there is an abnormality in the fatty acid pathway, then we will see this being raised more than normal people. A more specific marker is this 4-hydroxyl 6-methyl-2-pyranol, and this is the one that we saw in this patient that made us suspect this condition, but it's often absent, so not easy to diagnose HMG-CoA synthase deficiency. In a plasma acid, the blood spot or plasma acid carnitine, mostly we do blood spot acid carnitine. Actually, there's a raised C2 to C0, so slightly raised some ketone acid carnitine compared to the free acid carnitine. This is important to rule fatty acid oxidation disorder because the presentation of HMG-CoA synthase deficiency is similar to FAODs. So for example, MCAT deficiency have a pattern of the raised medium chain. So it is very, very important to send this, but it is not diagnostic. So both urine organic acid and blood spot gives us a suspicion of HMG-CoA synthase, but it cannot diagnose most of the time. This raised plasma free fatty acid is mentioned by Dr. Jasmine. So we need to have a ratio of free plasma free fatty acid to total ketone body of more than 2.5 because there's actually low ketone body being produced. Many labs, well, in the Ministry of Health, I'm not sure, there's no labs that is doing this, so I'm not sure about HUKM. And just now, as I mentioned, there's elevated triglyceride due to us needing to access glycerol. So the diagnosis to confirm it usually is by molecular analysis of the gene that is responsible. We can, well, the ability to measure HMG-CS, the enzyme activity, this HMG-CoA synthase, we can, so the enzyme is in the liver, we can biopsy it, but to measure it seems to be very complicated. We have never sent it for measurement. It's because there's actually an isoenzyme, so another enzyme, but the function is different for cholesterol synthesis. So if we measure this instead, then the liver enzyme would not be helpful at all. Now, so we did the molecular analysis for this patient in our hospital, and we found that indeed he has 2 mutations. So in autosomal recessive, we need to have 2 mutations. However, when we find 2 mutations, we need to clarify whether this enzyme is in chromosome 1. So we have 2 of the gene. In autosomal recessive, both have to be defective. So meaning both have to have the mutation, then only we have the disease. If both the mutation is in 1, there's still 1 functioning gene, and therefore he will not manifest. We need to decide whether the mutation is in trans or in cis. Usually to do that, we sequence the parents. So we did do the parents, and then to our surprise, actually the dad has 2 mutations. So we see that the dad has the 2 same mutation as the patient, and one of the mutation 1502 actually the mom. So the mom is a carrier, but the dad, again, the dad, we don't know whether it is in cis or in trans. We did his urine organic acid. He also has the marker. He is asymptomatic. He never have decompensation, and he also fasts during Bulan Ramadan. We continue then to do his parents to make sure that whether the dad is also in trans. So actually the dad has HMG-CoA synthase deficiency, but he is asymptomatic. This is very rare. This is not the usual case. The usual case would be the parents are carriers and they are asymptomatic. So, so in this, we need to test the father's siblings. They are also asymptomatic. They have not been tested yet. And then it changes the risk for the subsequent child. So if the parents of this patient of ours have a child, actually there's a 50% risk because he will always be a carrier from the dad. The dad will always pass on 1 which is affected, and then 50% from the mom. So very much higher risk than for the subsequent sibling. Fortunately, this condition, actually most of the time, the patients are healthy and do not require a special diet. So the patient on our follow-up is actually well, normal development, no more further decompensation. It is when they are in catabolic, so when they need more energy that we need to worry. So whether it's infection or fasting. In fact, they are not usually encouraged to fast. If they do, they really need to watch out whether there's any hypoglycemia. And this is a cause of sudden death in infants. So there has been death due to this condition. The treatment basically aims to prevent the usage of fat by providing lots of glucose during catabolic state. And then if the patient has symptoms, we always intervene when the blood glucose is normal. So we don't put up the drip. So if the patient come in vomiting, not taking orally, we do not wait until the patient cannot take orally, then we put up a drip immediately. Of course, any form of fat is contraindicated in this condition. Usually we don't really need to adjust the diet, although some centers do promote if we can avoid the high fat diet. I think we are late. So for hypoglycemia, I might skip this. Basically, we treat hypoglycemia regardless of the cause with sugar. And then do remember hyperinsulinism is also a differential diagnosis of hypoketotic hypoglycemia. But usually they may not have the Rayleigh syndrome that we see. And critical sampling is important if we still do not know the diagnosis, and critical sampling involves taking the inborn errors, bloods, as well as the hormonal workup for hypoglycemia. This one at the emergency department, I will probably also skip. It's just very similar. Correct the hypoglycemia, do our ABCs, correct the metabolic acidosis. Now, this is the one that we prescribe for our patients with HMG-CoA synthase deficiency, or for all the fatty acid oxidation disorders who are well in between the intercurrent illness. So when they are sick, actually they need more sugar. So we actually use the guideline provided by the British Inherited Metabolic Disease Group, and thankfully they make it available for free for everybody to check out. So we use a glucose polymer. Because there are conditions in Malaysia where they cannot take sucrose and our table sugar is sucrose. So usually, so for example, fructose 1-bisphosphatase deficiency also we do see in Malaysia, and they cannot tolerate fructose. So we use a glucose polymer. In the supermarket, this will be our glucoline, but we use carbory. So these are the dilution. We can tolerate more and more concentrated glucose as we grow. The most important thing is to remember when they're not well, we give this frequently. In BIMDG, they recommend every 1 to 2 hours. We tell our patients 1 to 3 hours. They must drink some sugar when they're ill until they get better. This is very, very important. It prevents the decompensation and keeps them out of hospital. All right. So, so just to let Jasmine know again that this HMG-CoA lies, you can put a comma there, and HMG-CoA synthase, and the table will still be correct to be used. All right, that's all from me.
Right. Thank you, Dr. Leong. Such a comprehensive and fascinating patient and the family. Interesting. We are very short of time, but I really want to ask the last question. How common is this condition, and are we under-diagnosing it?
Okay, so when I started, so I've been in this department for 10 years. When I started in this department, I think there were only very, very few, almost just 1 or 2. And now we probably have around slightly nearer to 10 that we know of. So it's very rare that we are picking it up. And one of the reasons is definitely it is being under-diagnosed. We hope that is because most of them are well, because the minute if they take sugar regularly, then, so for example, if the patient come in and we put in a drip, they're not so bad, the decompensation, actually they recover. And if we did not pick up those metabolites, which are not easy to pick up, then they won't be diagnosed. Like
the father, he's asymptomatic, he probably gets regulated when he's unwell, he takes sugar or what?
Sorry?
Or the father, probably when he's unwell, he knows how to seek for sugar or something like that.
So even if they're taking complex carbohydrates, so if they're taking their bubur and their nasi, they might just get over it as well, as long as they're eating something regularly. So thankfully, this condition actually can easily be prevented once we know the diagnosis.
But for this patient, he already came with encephalopathy once, so he has got the sick day plan. And all
definitely.
That. All right.
Definitely.
Okay. Thank you very much, everybody. I think you do agree with me. We have a very interesting case today, and Dr. Jasmine, I must say, you did very well for such a complex and difficult case. Thank you to all the panelists, Dr. Lee, Pei Chuan, Dr. Amirah, and Dr. Leong for your participation. I think we learned quite a lot today, especially for the medical student, how to approach hypoglycemia, metabolic acidosis, and rarer metabolic conditions. Thank you very much.
Thank you
all.
Thank you.
I think the medical student have to stay back for their quiz.
Ada quiz ya.
Yeah, that's right.
Tapi kalau